Hi, I'm Dr. Frank Johnson. I'm the founder of Sport Medicine Ultrasound Canada. I'm a primary care sports medicine doctor here in Calgary, Alberta, and I have my diplomate in sports medicine from CASM, and also have my registration in musculoskeletal ultrasound from America. So I want to talk with you today a little bit about having the upper hand over tendon and ligament injuries with a new innovative treatment. So the basis of the talk is essentially how SportVis is changing my practice and what I teach my students. Here's a picture of me teaching at one of our recent courses in Calgary. Yet again, another picture. We had 19 docs coming from all across Canada. We run about 100 to 200 people through our programs each year, and that's why Pendopharm wanted me to share with you my perspective about what my students want to learn, and I think what sports medicine doctors should know about ultrasound-guided interventions using SportVis for tendon and ligament injuries. So first thing is that it's a class 3 medical device that contains soft tissue adapted, biocompatible hyaluronic acid. Essentially, this is not a very viscous product as opposed to the hyaluronic acid products that we're used to using in joints. This is really not very viscous. When you open up the package, there's a small little bubble in it, and when you point the syringe upwards, you can actually see the air bubble traveling through the product. So it's really quite a non-viscous product. Of course, that's relative. It's significantly more viscous than water. Now, it was approved by Health Canada in November of 2020. This box in front of you contains 2 syringes of 1.2 milliliters of the hyaluronic acid solution. Each of the syringes contains 12 milligrams of the hyaluronic acid product. It was first available in April 2021, and Pendopharm's rolling it out over the course of the summer and into the fall of 2021. So it's intended to relieve pain and restore function in acute first and second degree ankle sprains. It also has the Health Canada indication for chronic, that is greater than 3 months, tennis elbow. Now, I personally think the greatest indication is going to be tennis elbow because it's a bit challenging to get to people early on in the course of a first or second degree ankle sprain, whereas people come to us all the time for tennis elbow. So its mechanism of action is it increases hyaluronic acid around the injured tendon and ligament. It provides lubrication and hydration to the affected site. So here's a picture from one of the studies. This was a study done by Petrella in London, Ontario, and it was released in 2010. This was a study released in 2007. It looked at pain reduction when weight bearing in people that had a first and second degree ankle sprain, diagnosed by a primary care sports medicine doctor, an emergency room doctor, or an athletic therapist. And they injected them, they wanted to inject them within 48 hours for the first one. And what we see is over the course of 712 days, we see a significant reduction in the VAS pain score when weight bearing. Forgive me, that was compared to placebo, which was a normal saline injection. Now for tennis elbow, you see a significant reduction from 15% reduction in pain after the lateral epicondyle was injected with a saline solution versus a 74% reduction in the VAS pain score in tennis elbow when the painful tennis elbow was injected with the hyaluronic acid product with the SportVis. So this was measured, I'll get to that in future slides here. So with ankle sprain, so we're going back to ankle sprain here, people got back to sport sooner. So 6 days earlier with SportVis. So if you do have somebody who has a big competition coming up, let's say they're a masters tennis player and they really want to get back on the court sooner rather than later, you can absolutely treat them with rest, ice, compression, elevation, and day 2, day 3, start some early mobilizations. But why not offer them a SportVis product? So again, this is early return to sport. Now, in this particular study, they didn't have anybody return to painful, no disability sport at any point during the trial. So that's an interesting difference. So essentially, it's a generally safe and well-tolerated treatment. It's been used in Brazil quite extensively over the last 10 years. It's been used in Europe for the last 20 years. There are other hyaluronic acid products available in Europe, but this is the only one of indicated. It's the only one licensed in Canada to be used for these products or for these indications. It's derived from a non-avian source, and there's been no serious side effects reported. So how does it work? So we're all familiar with hyaluronic acid in an arthritic joint. It increases lubrication, increases water content in the native, usually damaged articular cartilage and fibrocartilage of the knee, for example, or the hip. But in these soft tissues, it works a little differently. So when an injury first occurs, so we're talking about an acute injury here, a fibrin clot, so blood vessels will leak. A fibrin clot forms at the injury site, and the body increases hyaluronic acid production. So in this situation, when you inject SportVis, a SportVis injection will form a gel-like fibrin complex at the injury site, and a SportVis injection gently reduces inflammation rather than a massively potent inflammation reduction. For example, if you took Aleve 2-3 times a day, if you took ibuprofen 4-6 times a day, or you did a cortisone injection, that's a massive inflammation reduction. We all know that some level of inflammation is important for the healing process. So on the left is an artist's depiction of what a normal fibrin matrix looks like. Then the middle is a naturally occurring fibrin matrix, naturally occurring hyaluronic acid inside a fibrin matrix that the body naturally does. And on the right is, if you inject the SportVis, this is an artist's interpretation of what the fibrin matrix would look like with the additional hyaluronic acid available. So how is it administered? So in an acute first and second degree ankle sprain, the first injection you want to try to get in within 48 hours. Obviously, it's challenging to get somebody from injury to your clinic ready for an injection within 48 hours, but that's how it was done in the studies. And the second injection about 4 days after the first injection. Tennis elbow, first injection would be at the time of the patient's choosing, so for example, the time of consultation, and the second injection about 7 days later. Obviously, not everyone's schedule is going to work with that, but that's what the study did. So why hyaluronic acid for tendons? So if you do a lit search on PubMed, you can see that over the course of the last few decades, the results of papers being entered into PubMed with hyaluronic acid and tendon in the string has gone up significantly. So here's just a sample of some of the papers that you can find when you check this out on PubMed. And this is the available clinical evidence that Pendopharm wanted to highlight in this talk and in some of their other talks. So we see lots of ankle, we see 3 elbow studies, we see some studies for rotator cuff pain, rotator cuff impingement, rotator cuff tears. And then there's some others. And Pendopharm is going to be collating some of the international data, but they're also going to be doing a prospective trial here in Canada as well. So if you want more information about that, contact your local Pendopharm rep. So once again, there's a study of some of the available clinical evidence. So to understand how hyaluronic acid works for tendon and ligaments, I went to PubMed and I got digging into some of the tissue bioengineering studies. And this was a paper that was just recently published in Pharmaceutics in January of 2021 by some Italian researchers. So an important thing to know is that tendons are mostly water. Again, just like a human body, we're mostly water. They appear white because they're relatively avascular, and they're mainly made of an extracellular matrix based on 30% collagen, 2% elastin, and 68% water. Now, tendons start healing from the outside. So tendon injuries first repair by means of deposition of an initial matrix. The cells which take part in this early event seem to originate from the extrinsic component of the tendon, such as the paratenon, the epitenon, and the endotenon. Obviously, an endotenon is inside, but as you're about to see in the next slide, it can be considered an extrinsic component because the resident cells inside a tendon possess a limited reparative capacity. So in this paper, they demonstrate over here on the right, we see this is the macro architecture of the tendon surrounded by an epitenon. You can see within it there's many fascicles. This would be defined as a tertiary bundle, a secondary bundle, or a fascicle. And this is the endotenon. So you can see for the, compared to the macro structure, the endotenon is an internal structure. However, when compared to a subfascicle, a fiber, a fibril, or microfibril, the endotenon is actually an extrinsic structure. So in injecting our patients with SportVis, what we're going to be doing is we're going to be putting the SportVis adjacent the epitenon, adjacent, essentially outside the tendon, not inside the tendon. Here's another slide from this paper showing essentially the normal vasculature. So this is how essentially, anything that you eat that is going to become integrated into your cells, into your myofibrils, into your tenocytes, into your tendon collagen, will make it to the tendon via these blood vessels. Now, inside here we also see some tenocytes. These are the tendon stem and progenitor cells. These are the blue, and then we see the tenocytes in the green. The pink is the collagen fibers. The yellow is the ground substance, a big part of the extracellular matrix. So you can see a tendon is largely extracellular matrix that essentially nourishes the cells that make the collagen fibers. So we're going to put now, why are we not putting the SportVis inside the tendon? So the question is, where are you going to put it? This is 1.2 milliliters. It's 1.2 cubic centimeters of a product. And if there's disruptions here, slamming this into the middle isn't necessarily going to be helpful for the tendon. So essentially, to make it much more palatable for the patients, and to not disrupt the structure of an injured tendon or ligament anymore, we're going to put it adjacent the tendon. Here's from another paper, Journal of Orthopedic Research in 2015, just showing the same thing with the epitenon around the outside. Here's a scanning electron micrograph of the tendon macrostructure, and then a close-up of what the internal structure of the tenocyte looks like, and then an internal structure of a fiber and with the fibrils in it. So yet another picture from the paper. So we know that tendons attach muscle to bone. That's what we've all been taught. Now in my courses, we see that a lot of times the tendon will start up here. So lots of muscles and tendons have a bit more of a pennate or a multipennate, or almost like a feather structure, where the vein, the central vein is of a feather, has a whole bunch of fibers attaching to the outside. And most of our tendons are actually structured like that, but they do kind of come together and coalesce and become fibrocartilaginous structures that blend and interdigitate with calcified fibrocartilage structures, which then turn into bone. And this is where we see a lot of our injuries. So we're going to put the SportVis on the outside rather than slamming this 1.2 milliliter product into the injured structure. We're going to leave it on the outside for the cells to do their own thing and do with it as they need to. So the positive effect of hyaluronic acid can be attributed to the anti-inflammatory activity. The anti-inflammatory activity of the hyaluronic acid, enhanced cellular proliferation, and collagen deposition. This is from a paper from the use of hyaluronic acid after tendon surgery and in tendinopathies. So the benefits of hyaluronic acid over cortisone. We know that hyaluronic acid has an anti-inflammatory activity. It's a gentle one. Cortisone also has that, but it's profoundly it profoundly interrupts the normal process. We know that hyaluronic acid will enhance cellular proliferation. Cortisone does the opposite. And hyaluronic acid improves collagen deposition, and we know cortisone does the opposite. So now let's get into the clinical evidence, because this is where the rubber hits the road. What happens when you actually treat your patients with it? So Petrella is a doctor from London, and in 2010 he published the studies. Here it is right here. Robert Petrello, Cogliano, Decaria, Mohammed, and Lee published their paper. We're going to dig into it right now. So they recruited 331 Canadians from sports medicine clinics at the University of Waterloo, the University of Guelph, and the University of Western Ontario, as it was known at the time. So the average age of the participants was 49 years old, 55% were male. The average duration of symptoms was 18 months. So these are chronic tennis elbows that are not getting better on their own. The patients were assessed with a VAS score at day 7, 14, 30, 90, and 356. It was a blinded RCT using SportVis or normal saline injections. The injections were done at day 1, and the second one was done at day 7. The injection was done without ultrasound guidance, but it was done subcutaneously, approximately a centimeter distal to the lateral epicondyle. The VAS score was asked before the patients had a grip strength test and then immediately after they did a grip strength test. Here's the raw data. So what we see is at baseline, the hyaluronic acid group at rest had a mean VAS score of 8.5. Plus or minus 11.1. I have to imagine that's a typo. That should be 1.1. I just picked that up now for the first time. And in the control group, you see it's essentially the same, 8.4 with a standard deviation of plus or minus 6. Now, on day 30, after the hyaluronic acid injection, you see that VAS score come down to 2.2 at rest, and after the grip strength testing comes down to about 2.0. At day 90, that improvement is sustained both at rest and after grip strength testing, and at day 356, that pain reduction score is sustained. Now, compare that to the control group, where at rest, the control group was saline injection. The score came down to 7.1. However, after the grip strength testing, it went up to 9.9. See 6.7, 9.3, 7.7, 9.1. So essentially there is a significant, I'd say even profound, difference between the HA group and the control group that was sustained out to 356 days. And again, this is no small study. 331 participants is a good number. So here's what it looks like. This is the placebo group, or the control group as we prefer to call it. And we see that pain reduction at rest. And there's that significant reduction using the SportVis. So the results of secondary outcome is they monitored the return to sports that is pain-free and disability-free, and the average for the SportVis group was 18 days. And it was not achieved in any of the control group patients. So I think that's an important one. However, for my money, I think this is actually a more important slide. I'm going to come back to this. So where are we going to put the SportVis? We're going to put it outside where the injury is. So here is how SportVis is changing my practice and what I teach. I think it's a fantastic alternative to cortisone and PRP. What we see here is one of my buddies on the table with his right lateral epicondyle. I've got my ultrasound probe here. I'm injecting the SportVis subcutaneously. So on the screen here we see this is essentially his cutaneous tissue. Here's the needle coming in from right to left, landing just superficial to the tendon. Here's the lateral epicondyle of the humerus, and here's the footprint for where the common extensor tendon attaches. Here's the radial head over here. You can see a significant focal defect in the mid portion of the tendon. This happens to be in the area attaching to the extensor digitorum communis, going down to the middle finger and the adjacent two fingers. And he had profound symptoms. So how did it turn out for him? Well, I just spoke with him yesterday. I did the injection for him about a month ago. The first one about a month ago. The second was about 3 weeks ago. And he said between the cortisone, which he'd had 2 and 3 times, I think, PRP, which we did for him twice, he said this was profoundly better. His activity has improved. He has not been taking it easy. He's been building a tennis court in his backyard, shoveling, using heavy equipment, picking rocks. And he said, despite the abuse he's giving it, this tendon is feeling a ton better after the SportVis. So anyway, again, that's just one of those. It's nice to see it, to believe it with your own eyes. Now, not everyone's going to respond that way. Not all my patients have responded that way. But this was one of those ones that certainly got me intrigued to see how this might work in my practice. So again, here's another view of it, a zoomed in view. You can see that significant defect. So to be very clear, this tennis elbow was caused from chronic partial thickness tearing of the common extensor tendon, which is very different than a mild tendinosis or a radial collateral ligament tear, because the radial collateral ligament's down here. So why hyaluronic acid for ligaments? Well, once again, if we go back to PubMed and we search it, there's been an increasing number of papers published on it. This is what it looks like over time. So we know that acute ankle sprains are a single ankle sprain is a great predictor of a second ankle sprain. So 100,000 Canadians sprain an ankle every year. Rice, NSAIDs, immobilization, usually this is not going to be first or second degree, obviously. Physiotherapy only for those people who are motivated or can afford it. And up to 41% of patients are going to require a second line of treatment. So the clinical evidence that Petrella and his group put together was this. They recruited 158 Canadians. I suppose that represents the challenge of getting acute ankle sprains compared to chronic tennis elbow. Once again, Waterloo, Guelph, Western Ontario. Acute ankle sprains grade 1 or 2 diagnosed by an athletic therapist, an emergency room doctor, or a general practitioner who presented to a sport medicine clinic in less than 48 hours after the injury for a SportVis injection. Once again, it was a blinded RCT using SportVis plus rest ice compression elevation or normal saline plus rest ice compression elevation. The injections were done at day 1 of their presentation to the clinic, so that's usually within 48 hours, and day 4 of their presentation to the sports medicine clinic. Injection was done blindly to the ATFL. Now we know there's some limitations in accuracy, but once again, I think that can be washed out by the sheer number of patients. That was quite a lot of patients. So the pain scores were taken at rest with weight bearing and after walking 20 meters. So these were scored on day 4, day 8, day 30, day 90, and day 712. The primary outcomes were that we saw a significant reduction in weight-bearing pain from 4.9 to 3.8. Now, again, is that massively influential in my practice? Probably not, but it was statistically significant. Now, here's something that's a bit more important. The SportVis plus Rice, we got people back to pain-free sport on day 30 with a 71% frequency as opposed to a 42% frequency with the saline injection. So what's that look like? So sorry, I don't have more on that slide. What we'll do, but again, I guess the take home here is if you've got somebody who has an event coming up, a social event, a hiking trip, they're flying to Europe to walk that massive trail in Spain and they want to get back to walking sooner rather than later, you could certainly just use rest ice compression elevation, anti-inflammatories, put in a cortisone injection, wouldn't recommend it. Or you can offer them SportVis and say, look, I really think this gives you a better chance of getting back to pain-free sports sooner rather than later. So following a secondary outcome, so there were fewer recurrent ankle sprains at the 2-year mark. Again, so this is pretty significant. So now again, the sheer numbers, the absolute numbers were not massive. So out of 156 people, there was 16 recurrent ankle sprains in the placebo group or the saline group, and only 7 recurrent ankle sprains out of 156. Oh, well, I suppose it's half-half. So 7 recurrent ankle sprains out of the 78 that received hyaluronic acid. But again, that's a real number. That's not insignificant. And there were fewer days missing from sport. There were 50% fewer days at 2 years. So once again, we see the placebo group 41 missing days, 21 missing days. So essentially how SportVis might change my practice and what I teach for ankles. I think it's a fantastic alternative to rest ice and compression and elevation alone. I think there's some pretty good data there to show that there's reduced ankle sprains going out to that was 2 years, yeah. Obviously, the challenge is going to be to treat it within the first week, but my personal opinion would be sooner rather than later would be better. I do think it's realistic to get people in under a week. It's very realistic to get them in under 2 weeks, and the sooner the better. So my key takeaways from here is there's a new product available called SportVis. It's the first hyaluronic acid injection approved by Health Canada for treatment of tendon and ligament injuries. There's pretty good evidence in ankle sprain and tennis elbow that shows SportVis provides pain relief, fast recovery, and quick return to normal function. So the opportunities here, I think it's a safer option than cortisone. The ankle, you can return to sport faster. The challenges are going to be raising awareness for elbow tendinopathy. And the challenge for ankle sprains is going to be to treat the acute ankle sprains quickly. So this is what I'm going to be teaching my students on the courses. This is what I'm going to be telling my patients about. And thank you very much for your attention.